Approximately 385,000 Americans are living with AIDS, according to the Centers for Disease Control and Prevention. There was a time when infection with HIV meant a death sentence for most people. Hello, I'm Candace Rotolo, and welcome to our program, HIV+AIDS8. The best way to protect yourself from exposure and provide the best possible service to your clients is through increased education and understanding of this disease process. The human body is continually exposed to microorganisms normally found in and on the body and in our environment. When the body's immune system is intact, the individual is protected. When HIV destroys the immune system and interferes with its normal functioning, these microorganisms are not kept under control and can cause illness and even death. Since 1992, all blood donations in this country are tested for both HIV-1 and 2. Human immunodeficiency virus is a virus found in humans that attacks the immune system and creates a deficiency in how the immune system functions. AIDS is a group of medical problems brought on by the impaired immune system. For individuals to be diagnosed with AIDS, they must fit a definite description of the disease as defined by the Centers for Disease Control and Prevention. It is important to remember that AIDS is not any one disease. There are actually 27 different diseases and conditions that define AIDS. A person with AIDS can have one or several AIDS-defining conditions. Some of the conditions must be diagnosed definitively, and some may be diagnosed presumptively. Either method of diagnosis must be based on the CDC's criteria for an AIDS diagnosis. A person can also be diagnosed as having AIDS based on a specific blood examination and result. If a person with HIV has an absolute CD4 count, or T helper cell, of below 200, or the CD4 count is 14% or less of the total lymphocyte count, they also are diagnosed with AIDS based on immunologic criteria. It is important to remember that a person can be HIV infected, remain infectious to others through intimate contact, but not have AIDS for many years. It is not unusual for a person to have HIV infection for 10 years or more and not develop AIDS. There are also a handful of people who have been living with the HIV virus and have never progressed to AIDS, despite 20 years of untreated infection. They're called long-term non-progressors, or LTNP. Why and how they stay well remains a mystery. AIDS, as defined by the CDC, has been a reportable, communicable disease in the United States since 1983. HIV alone is not uniformly a reportable disease across the country. Usually, unless otherwise stated, when statistics are reported and discussed, it is based on reported AIDS cases and not cases of HIV infection. There are many people in this country who have HIV but have not yet progressed to AIDS. According to the United Nations Program on HIV/AIDS, 42 million people are living with HIV/AIDS. Deaths due to HIV continue to rise every year in the United States. For many years, the best that could be hoped for was that the antiviral medications would help keep the individual alive until there was a cure. This bleak picture began to change as new and exciting classes of drugs became available. The primary method that HIV has been transmitted is through sexual contact with a person who is HIV infected. It is also transmitted via contact with infected blood or blood products, as in sharing injecting drug equipment and receiving infected organs, tissue, or sperm. Also, an HIV-infected woman can pass it to her unborn fetus during pregnancy, childbirth, and breastfeeding. In the past, people have also been infected by receiving blood transfusion or blood products that were contaminated with HIV. For HIV transmission to occur, a sufficient amount of HIV and a port of entry into the bloodstream are necessary. It is important to remember that exposure to HIV does not necessarily lead to infection. If an infected woman takes AZT, an antiviral medication, during pregnancy and delivery, her chances of infecting the fetus are reduced to approximately 8%. Based on the study results, it is recommended that all women be offered HIV testing and counseling during their pregnancy. Some states have already made this a mandatory component of prenatal care because of the dramatic reduction in the rates of perinatal transmission of HIV. As we mentioned earlier, another form of transmission is from a blood transfusion. All donated blood and blood products used in the United States are tested for HIV and destroyed if positive. Also, donors are screened through a series of specific questions about behaviors that would increase their risk of being HIV infected. After exposure, it can take from several weeks to 6 months for enough antibodies to develop to detectable levels. The risk of getting infected with HIV in the United States from a blood transfusion has been almost eliminated. Humans tend to deny that specific events they observe happening to others will ever happen to them. It's easy to deliver a prevention message, such as exercise daily, but it's much harder to implement the behavior change required to accomplish it. The same holds true for HIV prevention education. There is no cure for HIV/AIDS, no vaccine, and treatment options are expensive and sometimes ineffective. Prevention of new infections is the key. Abstinence from sexual activity is the only sure way to not become infected with HIV through sexual contact. Prevention measures surrounding injecting drug use ideally would be to abolish the behavior in the drug users by getting them into drug treatment and off drugs. For those unable to stop the behavior, the use of bleach for cleaning syringes and needles is recommended. This reduces the transmission risk for injecting drug users who share needles. It is important to remember that the use of bleach is not 100% effective. While the use of non-injecting drugs like alcohol, marijuana, and cocaine does not directly lead to the transmission of HIV, the abuse of these substances can contribute to the spread of HIV. Whenever judgment is impaired, measures to prevent the transmission of HIV are threatened. The original intent of HIV testing was to screen the supply of blood donated for medical use. Since there was concern that people at risk for HIV would donate blood to find out their HIV status and increase the risk of contaminating the blood supply, alternate testing sites were opened around the country. Many of these sites are operated by county health departments and follow guidelines established by the Centers for Disease Control and Prevention. Testing is also available from private physicians, hospitals, and drug treatment clinics. Depending on the laws of the individual state, HIV testing is available confidentially or anonymously. For example, in Florida, a positive test result must include a second test confirmation, and results must be given with post-test counseling. Counseling must involve the meaning of test results, any further testing, measures for preventing transmission, location and the availability of health care, social and support services, and benefits of locating and counseling of infected persons. Positive test results are reported to the county health department. Confidential testing is where identifying information on the individual is collected and their test is maintained in a confidential medical record. Anonymous testing is where no name or locating identifiers are obtained on the individual tested. The person being tested is provided a unique identifying number. Not every state allows anonymous testing, but all have confidential testing available. The enzyme immunoassay, or EIA, which the Food and Drug Administration approved for screening the United States blood supply in 1985, is used as an initial screening test, and a confirmatory or supplemental test is always required on any reactive EIAs. There are several testing methods available for use as confirmatory tests. Different labs use different combinations of the tests, but all EIAs must be confirmed by another form of antibody test before an individual would be told they have a reactive HIV test. The point at which infected blood tests HIV antibody positive can range from 2 weeks to as much as 6 months after infection has occurred, but most people will test positive within 3 months. This change from HIV negative to positive is referred to as seroconversion. The time period from infection with the virus until seroconversion is often referred to as the window period. HIV can be transmitted during this window period, but the antibody has not yet reached detectable levels. In 2003, the FDA approved a rapid test using a single drop of blood that produces results within 20 minutes. The goal is to develop testing methods that are easy to use, low cost, and with a safer collection method for individuals and healthcare workers. Once an individual becomes infected with HIV, the rate at which their immune system is compromised, allowing the disease process to progress, varies from individual to individual. An important component of staging and evaluation is now widely available. It's called viral load testing. This is a blood test in which results show the amount of active and circulating HIV in the body at the time the blood sample is drawn. Thanks to dramatic advances in treatment, antiretroviral medications can suppress HIV replication, prevent disease progression, and avert the failure of the immune system that occurs with AIDS. As a result, HIV infection has become a chronic and manageable illness for those who live in countries where antiretroviral therapy is readily available. Successful antiretroviral therapy requires nearly perfect adherence to a complex medication regimen. Less than perfect adherence leads to drug resistance. There are 5 specific classes of drugs available for the treatment of HIV disease. These medications inhibit or interrupt the replication or reproduction of the virus in CD4 cells. They are nucleoside analog reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, protease inhibitors, nucleotides, and fusion inhibitors. The drug cocktail has worked dramatically for many individuals living with HIV disease. People who have been so weak they could barely walk have found their energy level returning to almost normal. Some who have been on disability and unable to work are considering returning to work, at least on a part-time basis. Many people with HIV disease are looking and feeling better than they have in years. But it's not a cure, and it doesn't work for everyone. Adhering to the treatment regimen on a consistent basis and dealing with the multiple side effects of some of the medication is difficult for many people to manage. With the medications of the cocktail and other medications used to prevent opportunistic infection, a person might be taking as many as 30 to 40 pills a day. Some medications must be taken with meals, some on an empty stomach, some 2 hours after a meal, and on and on. In situations like this, multi-day pill boxes and medication alarm systems can be useful. The major concern with taking the cocktail on an irregular basis is the potential for developing the drug-resistant virus. Then the treatment options are limited. Treatment failures with the new regimens are already being seen. Some people have been given every combination of the medication only to have the CD4 cell count continue to drop and their viral load continue to rise. Even though there have been dramatic advances in the treatment of HIV disease, the reality is still harsh. Treatments are expensive, difficult to manage, have multiple side effects, and do not work for everyone. In a discussion of management of occupational exposure to HIV, a few terms must first be defined. The CDC provides the following definitions. Post-exposure prophylaxis, or PEP, is treatment and medical intervention for a healthcare worker after a workplace exposure to HIV. Healthcare worker, or HCW, is defined as any person, an employee, student, contractor, attending clinician, public safety worker, or volunteer whose activities involve contact with individuals or with blood or other body fluids from individuals in a healthcare or laboratory setting. An exposure that may place a healthcare worker at risk is defined as a percutaneous injury, such as a needle stick or cut with a sharp object, contact of mucous membrane or non-intact skin, such as when the exposed skin is chapped, abraded, or afflicted with dermatitis, contact with intact skin when the duration of the contact is prolonged, such as several minutes or more, or involves an extensive area with blood, tissue, or other body fluids. Body fluids include semen, vaginal secretions, cerebrospinal, synovial, pleural, peritoneal, pericardial, amniotic fluids which have an undetermined risk for transmitting HIV. It must be noted that exposure to saliva, tears, sweat, or non-bloody urine or feces is not considered an exposure that would require HIV post-exposure follow-up. The rationale for post-exposure prophylaxis is based on information that indicates that HIV infection does not occur immediately after exposure, leaving a brief period of time in which antiretroviral medication may interrupt viral replication and thereby prevent infection. Many factors must be taken into consideration and influence the PEP recommendations, including the risk-benefit of PEP to exposed healthcare workers. An exposure report should contain the following information: date and time of exposure, details of how the exposure occurred, the type and amount of fluid or material and the severity of the exposure, details about the exposure source case, which includes HIV status if known, and if positive, the disease's stage and history of antiretroviral therapy, and viral load. The exposure site should be washed with soap and water, or in the case of mucous membranes, flushed with water. Evaluation of the exposure should be based on the potential of the exposure to transmit HIV, the type of body fluid involved, the route and the severity of the exposure. For example, a few drops of urine on skin that is intact would not require PEP. But a large bore hollow needle that has been removed from a person's vein or artery and results in a deep puncture wound in the healthcare worker would pose a great risk and would require immediate follow-up. The source of the exposure should be evaluated for risk of HIV infection that includes medical history, laboratory information, clinical symptoms, and a history of high-risk behavior for HIV infection. If the source case is known HIV positive, additional information should be gathered that includes stage of infection, CD4 count, recent results of viral load testing, and current and previous antiretroviral therapy. If this information is not readily available, the post-exposure plan should be initiated. The regimen of PEP medication for the healthcare worker can always be altered at a later time if the virus is shown to be resistant to a particular medication. If the source case has recently engaged in high-risk behaviors for HIV and therefore could be in the window period, follow-up testing at 3 and 6 months post-exposure is recommended. HIV antibody testing should be done to establish the serostatus of the worker at the time of exposure. Other important information in the evaluation process of the healthcare worker should include any medication currently being taken and existing or chronic medical conditions. Certain medical conditions could influence the choice of medications for PEP. Many factors influence the PEP. All information must be compiled and evaluated by a medical provider familiar with the recommendations of the CDC for prophylaxis. It is important to know that PEP should be started, if necessary, within a matter of hours after an exposure, not days. An exposure should be regarded as an urgent medical situation and handled accordingly. All employers of healthcare workers are required to have a protocol in place to manage a worker's exposure to HIV. Your responsibility as a healthcare worker is to know and follow universal precautions, be familiar with your institution's protocol on handling exposures, and report any exposure immediately. Before coming into contact with different types of body fluids, whether it is blood, wound drainage, vomit, stool, urine, semen, vaginal secretions, or saliva, healthcare workers must make sure they are wearing the appropriate personal protection equipment. The equipment should be readily accessible to the healthcare worker in the client's room, laboratory, therapy room, or anywhere they may be needed. You are probably most familiar with disposable latex gloves. Remember, gloves and any other personal protective equipment must be changed between clients. And you may need to change your PPE with the same client when you do a different procedure, such as wear one pair of gloves to help clean an episode of incontinence, and another pair when you do mouth care. Always wash your hands thoroughly before and after wearing gloves. Gloves are not a substitute for hand washing. Gowns and face coverings must be used if there is a possibility of being splashed while irrigating a wound, suctioning, or pouring something from one container to another. Face shields and eye protection are needed when there is a potential for splashing, spraying, or spattering of blood or other potentially infectious materials. Handling sharps can place you at risk of exposure to blood-borne pathogens such as HIV and hepatitis. Engineering controls should be in place, which include puncture-resistant containers and needleless systems. Never try to bend, recap, or break a needle or sharp. Dispose of them in a puncture-resistant, leak-proof container. Remember that the sharp is rigid, and therefore disposing of the sharp is critical. Sharp containers must be located close to wherever sharps are used. Whether you are handling the sharps or not, you still need to know the protocols for their placement and their disposal. Employers must provide all employees with sufficient warning through the use of labels, signs, and training to eliminate or minimize their exposure to blood-borne pathogens and hazardous waste. There are OSHA requirements and state regulations regarding biohazardous waste. Biohazardous or regulated waste means liquid or semi-liquid blood or other potentially infectious materials or contaminated items that could release potentially infectious materials during handling. Let's examine spills, linen management, and disposal of wastes. If someone dropped a test tube full of blood or a bloody urine container, the important thing is to clean up the spill quickly before it dries. Wear protective gloves. You may also need a moisture-resistant gown or apron depending on the extent of the spill. You will want to use a broom or other sweeper for the broken glass. You do not want to pick up the broken glass with your hands, even with gloves on. Discard the broken glass in a puncture-resistant container. Wipe up the blood with a disposable cloth. Don't wipe in a way which spreads the spill. Then pour a disinfectant on the spill. You need to use an EPA-approved disinfectant. A diluted bleach solution of 10% or any other EPA-approved disinfectant that is effective against tuberculosis can be used. They will disinfect a surface contaminated with blood or other body fluids. Follow the directions for the disinfectant carefully. Let the disinfectant sit on the surface for 10 minutes, then wipe it up with a second clean disposable cloth. Remember that the contaminated paper towels or disposable cloths are biohazardous waste, which must be disposed of properly. If you use rags, they can be laundered with a 10% solution of bleach and detergent. Once the area has been cleaned, use the bleach solution again, wiping clean one more time. Remember, you need to clean the spill as safely and quickly as possible. It must be repeated. Do not pick up broken glass with your hands, and always wear gloves. Let's discuss linen and laundry. Hand washing and wearing gloves are necessary for handling soiled linens. And a long-term care facility, which has universal precautions in place, follow the facility directions in bagging laundry. In a home setting, heavily soiled items must be rinsed, solid organic material flushed down the toilet, and laundry pre-soaked for 10 minutes in a 10% bleach solution. All soiled clothes and linen should be placed in a plastic bag and kept separate from household laundry. When washing clothes, begin by shaking laundry from the bag into the washer and then wash immediately with 1 cup soap and a 10% bleach solution. Cleaning is key to reducing microorganisms. Cleaning is removing all foreign material, such as soil and organic debris, from objects, including inner channels and accessory parts. Soiled equipment should not be placed directly on unprotected environmental surfaces. Always clean an item under running warm water. Follow the manufacturer's recommendations for cleaning, and clean items with non-abrasive implements. You may need to use a brush to clean small holes or lumens, and disinfect or sterilize the brush daily. After cleaning, rinse the item with an abundant amount of tap water or distilled water and dry it thoroughly. Inadequate cleaning leaves microorganisms that can cause harm to the healthcare worker and the client. Cleaning must be conscientious and correct, or it gives a false sense of security. If you need to package and transport biohazardous waste, follow OSHA, state, and local regulations, as well as the written policies and procedures of your agency or facility. Nurses are in a unique position as educators to promote early intervention, prevent or reduce risks, and to maintain health and wellness, or when it's too late, to encourage compliance with treatment. Knowledge of and adherence to universal precautions are a healthcare worker's greatest protection against a workplace exposure. I'm Candace Rotolo. Thanks for watching.